and welcome to this webinar today, which is focusing on can and should charities and social enterprises play a bigger role in the delivery of public services. This is the first in a series of 7 Health and Care Futures webinars that are going to be taking place over the next few weeks as part of a programme of activities to mark Turning Point's 60th birthday year, which is very exciting for us. So thank you all for being here. Since we were founded in 1964, our organisation has grown year on year, and last year we supported over 197,000 people. We're very proud of our social enterprise identity, which I feel underpins our approach to financial sustainability, our excellent levels of colleague engagement and low staff turnover. And most importantly, to the quality of the support that we provide. 96% of our CQC registered services are rated good and outstanding. So last year, Turning Point delivered £142.5 million worth of social value in the communities where we deliver services. We're also very proud to be part of a wider family of third sector mission-driven organisations delivering vital public services to many people. And we really fully recognise the vital role that smaller community organisations play. And each year we invest in smaller organisations, with last year seeing us invest £4.5 million local VCSE organisations. In our 60th year, as we reflect on how much society and the health and social care landscape has changed, we also are looking, of course, to the future. And the Health and Care Futures webinar series is designed to examine some of the big challenges facing the sector. And we're really delighted to have a fantastic panel with us today to discuss the VCSE sector and the role that it has to play. Firstly, we've got the Right Honourable Patricia Hewitt with us. Patricia started her career working in the third sector before becoming MP for Leicester West between 1997 and 2010. In 1998, she was appointed Economic Secretary to the Treasury, and in 1999, she became a Minister of State for Small Business and E-Commerce at the Department of Trade and Industry, and created the Social Enterprise Unit. Patricia joined the Cabinet in 2001 and served as Secretary of State for Trade and Industry from 2001 to 2005 and Secretary of State for Health from 2005 to 2007. Today she's Chair of NHS Norfolk and Waveney Integrated Care Board, and in 2023 Patricia led a national review of the oversight and governance of integrated care systems. It's lovely to have you with us, Patricia. We're also joined by Peter. Peter waving there, by Peter Holbrook. Peter is the CEO of Social Enterprise UK, SE UK, a position he has held since January 2010. SE UK is the national trade body for social enterprise and represents a wide range of social enterprises, regional and national support networks and other related organisations. SE UK works to promote social enterprise as a model for changing both business and society. Peter has established, developed and supported hundreds of diverse social enterprises over his career. He's advised government task forces in the UK and overseas and served as Social Enterprise World Forum's board chair until 2015. In 2015, Peter was appointed CBE. Welcome to you too, Peter. And our final guest speaker is Eleanor Youdell, the Business Development Manager at Double Impact. Double Impact is a lived experience recovery organisation, also known as a LERO, working across the East Midlands. Double Impact supports people in the early stages of their recovery from drug and or alcohol issues, offering vital support around education and housing, a sober spaces cafe and peer support. They have around 80 staff and 85% of them identify as having lived experience. Turning Point partners with Double Impact in Lincolnshire, and Eleanor has worked for them since they were just 2 people. Today, they are the largest Lero in the country, and so she well knows the challenges of working for very small voluntary organisations and also the challenges of working for a growing organisation. So welcome to you too, Eleanor. Today's focus is to discuss the question, can and should charities and social enterprises play a bigger role in the delivery of public services? Research indicates that charities and social enterprises currently deliver around 50% of health and social care services in the UK. The voluntary community and social enterprise sector is an important partner for statutory health and social care agencies and plays a key role in improving health, well-being and care outcomes. Legislation and strategy documents such as the Health and Social Care Act 2012, the Care Act 2013, the 5-Year Forward View 2014, the next steps of the 5-Year Forward View, and most recently the NHS Long-Term Plan have all recognised this, and they have promoted the role of VCSE or VCSEF organisations in improving outcomes. These organisations improve health outcomes and tackle health inequalities not only by delivering services, but also by shaping their design and advocating for, representing and amplifying the voice of service users, patients and carers. As we know, their input is essential to a vibrant local health economy. As the demand for effective and sustainable solutions grows, we'll discuss the unique strengths that these organisations bring, the challenges that they face, and the implications for policy and practice. So I'm going to ask each of the panellists to make some opening remarks, and I'll then ask some questions, following which there'll be an opportunity for questions from all of you. As we proceed, if you have any questions and comments, can you please add them to the Q&A? There's a Q&A symbol at the top of the screen. If you click on that, you can ask your question at the top of the screen, and please do include who you are and where you come from. You can also respond to others' questions and comments, but unfortunately you won't be able to verbally ask a question yourself due to the webinar format. But I will keep an eye on the questions and will ask them on your behalf when we get to the discussion and as time allows. So I hope that was all clear. And now to our panel, and I'm going to pass over first to Patricia. Can and should charities and social enterprises play a bigger role in the delivery of public services? Thank you, Patricia.
Julie, thank you very much indeed. Can I just check that everyone can hear me all right? All working? Yeah, lovely. It's such a pleasure to be here with you, with Turning Point, which is an organisation I've known and admired for actually many decades, and to be on this panel with both Peter and Eleanor. And it's great to know that there's such an amazing mix of people from Turning Point all around the country, from local government, from the NHS, from many other organisations and sectors here at the webinar today, because it's this deep expertise and experience that all of you and your organisations bring to your local health and care systems. You know, that's the real strength of the health and care system, and specifically of integrated care systems all around the country. So, Julie, the answer to that question is absolutely yes. So let me elaborate with a couple of minutes of sort of introductory comments. For me, the key issue that underpins all the obvious problems, the headline-grabbing problems that we're all grappling with, problems of finance, of waiting lists, of performance, of poor quality, and so on. All of those problems are really symptoms of something much bigger, and that is that our model of health and care is broken. Fundamentally, we make the mistake of thinking that a policy for the NHS is the same as a policy for health and care. And of course, as we all know, it isn't. And the simple reality is that if we keep trying to meet 21st century needs with a 20th century model of care, we will never have enough staff, enough hospital beds, enough money, enough of anything to care for a population that is increasingly ill, where more and more people are living, sometimes from birth, with very complex physical and mental vulnerabilities and needs, a population that, of course, is also aging and that is increasingly unequal. We will not be able to meet our health and care needs, let alone achieve the health and well-being that we all want. That was very much the message of the independent review that I did last year around the NHS and integrated care systems. And Lord Darcy's recent report says exactly the same thing, more eloquently and with, frankly, even more shocking data than I was able to marshal. So when we're streeting our new health and social care secretary, talks about his 3 shifts, I think he is absolutely right. And his 3 shifts, of course, from hospital to community, from illness to prevention, from analog to digital. That is exactly the scale and the nature of the transformation, the new model of care that we need. And actually, it's what, as many of you know, it's what is actually happening in many parts of the country already, but not with the speed or at the scale that we actually need. The other thing I want to say, which again was a key theme both of Lord Darcy's report and certainly of my report, was really 2 points. One is, as we all know, people's lives are complex. You know, when somebody goes to their GP surgery, maybe repeatedly, because of migraine and stress and a whole series probably of other issues, actually the underlying problem and the most urgent problem may not be something that, you know, a prescription, an antidepressant or whatever is actually going to make any difference to at all. It may well be the mold on the wall of the house or the appalling job conditions they're working in or a whole host of other things. In other words, those wider determinants of health that, as we know very well, account for well over half, probably 80%, which is the general view of the health and well-being that all of us enjoy or do not enjoy. So people's lives are complex and health is not the same as the NHS, even though, of course, the treatment that we get and need from the NHS is absolutely vital and often life-saving. And if we're going to create the new model of health and care that we need and can start to see in many parts of our country, this isn't about doing things to people, it's about doing things with people and their carers and their families and communities. And of course, what that means, my final point, none of this can be done without social enterprises, without voluntary community and other groups. They are absolutely critical partners, providers, they're critical to the NHS and other statutory bodies, both as partners and as providers. They are a critical part of most people's lives, daily lives, and they are a critical part and critical partners within the wider health and care ecosystem, which integrated care systems, of course, convene and are designed to transform. So I'm going to stop there, Julie, but I hope that will help by way of introduction.
Thank you very much, Patricia. That was perfect introduction. So thank you for that. And I'm going to pass over now to Peter Holbrook. Thank you, Peter.
Hello, everyone. Lovely to be with you. And first of all, can I just say that that was an absolutely perfect opening statement from Patricia. And rather than seek to duplicate much of what she said, let's see if I can add some complementary commentary to proceedings. So in answer to the question around should the role of charities and social enterprises be more prominent in public services, I probably have two succinct answers. Yes, probably, and yes, but. For me, it's not really about the specifics of the structures that are providing services in our communities. I think it's much more around the ambition we have to create the opportunity for communities and individuals to participate and contribute to their own health and well-being, and for fundamentally public services to shift from being providers to being genuine partners with our communities and our people. And I think when we talk about NHS and social care, particularly with the Labour government, we tend to always think about Bevan, right? The great, wonderful pioneer and architect of our Bondi NHS. Maybe perhaps because he was a Liberal, we perhaps forget to think about Beveridge, actually. And Beveridge, of course, the architect of the modern welfare state, not only created that kind of landmark report back in, was it 1948, but more so in his later life, reflected about aspects of his original work that were lacking. And one of the areas that he identified was the role of civic participation within both welfare and health. And I think we have lost sight of that. I think we continue to see these services as services that are delivered to the public rather than with the public. And charities and social enterprises have this kind of unique contribution in that regard. So first of all, I've worked for some wonderful charities in my life, but I'm going to tell you why I have a problem fundamentally and philosophically with the notion of charity. There's some great charities out there, and I'm willing to celebrate them individually and applaud their work, of course. But if we look, for example, at the very notion of charity, there tends to be an expectation around philanthropy and volunteerism. And actually, I think that is a bit of a challenge. I think when we talk about access at the services free at the point of access, I think we need to ensure that we don't over-rely on the philanthropy and goodwill of others to underpin basic services to our people, to which I think they have absolute right. So I think there is also a bit of a problem, I think, with the very structure of charities. And so traditionally, we see the trustees of charities across the UK are dominated by particular age and characteristics and don't represent the diversity that we need to ensure sits across and throughout our governance. We've had a long-term problem, I think, with the kind of inverse care law around those that are the most vulnerable in society are probably least likely to access service. And that continues. That's partly because we have huge issues within the NHS around diversity in governance, but I think we also have that mirrored in many charities, and I think we have to acknowledge that there is a democratic deficit within that model. But let me come on to social enterprises, because this is an area that's really kind of, close to my heart, as you might imagine. And I'm not here as a champion for social enterprise because I'm the chief executive of social enterprise. It's something that I've learned as a practitioner over years, the power of participation. I know you practice this, you are a charity, but you are a social enterprise. You wear that badge proudly because your culture speaks to social enterprise. And I think what we see is actually that commitment to run a business, to run a profitable business, not being scared of using the language of business to drive high quality services, to speak independently to truth and power, and not be dependent on the interests of our, philanthropic funders or our charitable trustees. And the power of workforce representation in social enterprise, the power of the role of the worker is not and should not be in conflict with that of the ultimate beneficiaries of charitable work. And again, social enterprises recognise the nature of serving multi-stakeholders and not becoming too dominated or focused on a specific range of single beneficiary types. So, look, right across public services, as Patricia has said, we have, huge challenges. They are in crisis and they will stay in crisis unless we think differently. And I think the current systems and structures we've got in place are proving perhaps to be rather inadequate. And I'm the last person that would call for yet more reform of the NHS. But what I would say is we need reform of public service markets. We see still multinationals, private equity run businesses coming in and doing very, very well out of our public service markets, whilst often charities and social enterprises are expected to pick up the bits of public service market failure, the bits that the private sector don't want to touch, where margins perhaps are too limited or the challenge too complex. And I don't think we should be seen as kind of providers of last resort, and I think too frequently we are. I think we fall often between two stools. On the right, we have kind of governments that increasingly celebrate the notion of free markets and cost and commissioning being blind to purpose, organisational structure, the treatment of staff and workers, the impact on the environment. Or we see people on the left increasingly trying to bring services back in to local government or international government. And I think that can be a challenge too, because let's be honest, the state does not have the best record in social care. We have seen huge inadequacies in the system under both state and private sector provision. I think increasingly on the right, you're seeing public sector markets being dominated by hedge funds, private equity firms, private businesses that are making profits in excess of 20%, are fundamentally de-skilling the workforce, driving down quality and cost, and simultaneously walking away with very significant payoffs through intricate mechanisms like price transferring to overseas holdings companies, money that's not even taxed in this country. And they're not just taking the reward, they're taking no risk, because what we've seen when these businesses do kind of come into public sector markets, we often see that it's actually the state picking up the pieces when things go wrong. And I'll remind you of the collapse of Southern Cross care homes not so long ago, where the government had to step in and keep old people in care homes for fear of a huge issue of old age homelessness. There are many challenges. Social enterprise isn't just there to complement the public sector or indeed the private sector. I think it stands the test of being a model fit for the future, not only in public service markets, but right across the economy. Just think about what social enterprise is. It's about being purposeful, having a purpose beyond just profit maximizing. And I think given the complex crises that we all face, the interdependency of us all on a healthy global economy, the needs to try and address the challenges we face, not only through political leadership, but through the shape and nature of our very economy. I like to call it a well-being economy, that notion that everything is working in the same direction, that we're not pulling it at different angles, we're not seeing economic productivity as a threat to worker rights, for example. We can achieve, I think, balanced outcomes for everybody. We can give communities greater control, greater democratic opportunities within their communities to oversee responsibilities for public service delivery. And we can move to a different kind of thinking around not just how we deliver public services with the public rather than to the public, but how we can kind of restart kind of economic activity and opportunity within the communities that have been so poorly served actually for decades. The wider determinants of health, I think, are really important here. We can't just assume that the NHS or any part of public service can just pick up the consequences of a free and open market economy. We see the consequences in terms of the social drivers of ill health now. And we have to look more, I think, to Beveridge than Bevan at this point. We have to open the doors and see that mission-led organisations can be true and proud partners of our NHS architecture in the short term and across public services. But I would go further. I would challenge the right of private sector businesses in these markets, particularly those working with most vulnerable people, to actually operate. I think your licence to operate has to be aligned to a public service ethos and a public service benefit. And I think that needs to be constituted in organisations. And for those that are working with the most vulnerable people, kind of mission alignment, rules in governance that direct people to representation, transparency, openness and accountability are absolutely fundamental if we're going to kind of avert the crisis we're now seeing, for example, in children's residential. So yes, much bigger role for public services, I think, for social enterprises. The experience hasn't been great, but a much bigger role for social enterprises throughout our economy. Thank you.
Thank you, Peter. And just before I pass over to Eleanor, can I just remind everyone, if you've got questions to ask, can you please put them into the Q&A for us? That would be really helpful. Thank you very much. And Eleanor, over to you now. Lovely to have you here.
Thanks, Julie. Yeah, I agree with them. There was a lot to think about in what Patricia and Peter have just talked about. But yeah, in terms of whether VCSEs should be delivering public services, then to pick up on what Patricia said, absolutely, because, you know, because of their deep expertise and experience in their particular area, and, you know, having worked in this one charity for the past sort of 20 years and seeing it grow, I obviously know that we have that depth of experience in the area that we work in, and that is something that is extremely valuable, and it can't be something that is kind of faked or just quickly attained by another sort of organisation. So, you know, we've only managed to kind of still exist and grow to the extent that we have, because we're sort of definitely on the small end of being a medium-sized charity, but we are no longer one of the very many small and tiny micro charities, but we could well be. The only reason that we're not is because we have worked extremely hard over the years to form the kind of partnerships which have enabled us to compete for this public funding, and we've been relatively successful in doing so. But obviously there are a lot of challenges involved in operating within these structures and frameworks, and as I'm sure we'll go on to talk about. And I think, you know, what Peter was saying and what you were saying as well, Patricia, around the need for, you know, a really fundamental change. And I think, you know, that shift really needs to be largely in the power dynamics, you know, the imbalance of power between funders and providers, but also between statutory providers and VCSEs. And also with, you know, the VCSE sector is also so diverse that there are also, you know, that can also come into play just within the sector itself. So yeah, there's a lot to think about. But yes, absolutely, they should. But what can we do to make that possible?
Thank you. Thanks, Eleanor. Thank you for your comments as well. So I think in terms of questions, I've got a question initially I'd like to pick up, if I can, Patricia, with you. You mentioned ICSs in the role of convener in the system, and I know you've been involved in writing a big report on ICSs as well, haven't you? And I wonder what role you think ICSs could play in fostering kind of stronger, more collaborative partnerships between the NHS and VCSE providers, especially perhaps those focused on marginalised communities.
Thank you, Julie. So I perhaps not surprisingly, but I do see integrated care systems in England, and then the equivalents obviously in Scotland, Wales and Northern Ireland, as absolutely part of the way forward. And I'm not sure, we haven't really got time to take an opinion poll, but I'm not quite sure how many people on this webinar are already involved in their own local integrated care system. But essentially, we've got 42 integrated care systems in England. And although we've been going in an informal way, non-statutory, for several years, the really big change came with the 22 Health and Care Act that put us on a statutory basis and crucially went through Parliament with cross-party support. And Labour, Wes Streeting specifically, has made it very clear, he is not proposing a new legislation or yet another. I think the best way of describing it is disorganisation of the NHS. So we've got those structures there. Now, they vary hugely in size. The smallest would be about 800,000 people. The biggest, like Greater Manchester, you're talking nearly 4 million people. You've got some that are in really urban areas with very diverse and disadvantaged populations. You've got others like the one I chair in Norfolk and Waveney. We cover just over 1 million people in a very big rural and coastal geography. And what we've got, if you just look at the average figures, we're above average income. Actually, what that conceals is massive inequalities and deep disadvantage in many of our left behind rural and coastal communities. So, they're all different, is the point I'm making. Mm-hmm. But from the point of view of social enterprises and the wider sector, the crucial thing is that an integrated care system includes an integrated care board, which is the NHS bit. I chair that, brings together all the fragmented bits of the NHS. But then you've got an integrated care partnership. And that brings together all the partners. And what the Act says is the partners are the NHS, local government, the voluntary sector. Absolutely crucially, it's in there as part of that wider partnership, social care providers, other statutory organisations, and so on. They, different ICSs will put their partnerships together in slightly different ways, but a common thread is the presence of people from the VCSE sector. It doesn't mean there are enough of them. People will argue about whether they're the right ones in their particular area, but you've got that at the level of the whole system. But then within that, and particularly important in the very large integrated care systems, you've got these things called place boards, typically at the level of let's say a borough council, a unitary authority. And again, that's an opportunity where the voluntary and social enterprise sector can be at the table. And in many, many systems, we're one of them, but in many, many systems, we're now moving much more rapidly to ensuring that there is a proper, much more, it's not properly equal yet, but a much more equal partnership with the sector and people from the sector involved in the myriad number of working groups and pathway redesign groups and all that sort of thing, as well as being there at the table as the integrated care system decides on its overall strategy and its joint forward plan. This is work in progress. Lots of you on this webinar will have examples of where it isn't working the way it should be, but it is work in progress. And I think we've got a really helpful statutory framework. And I also think the new government's emphasis, quite rightly, on the role and of the combined mayoral authorities and the leadership of the mayors, that is another opportunity, again, for the voluntary and wider sector to become, if they aren't yet, much more equal partners in this process.
Thank you. Thank you very much, Patricia. And Peter, I saw your hand up there. I was going to come to you anyway. So if I can ask you a question, and then maybe you can also either add on yours or incorporate what you wanted to say, that would be fantastic. Because what I was interested to know is, off the back of what Patricia was just saying, I mean, what would you say SE UK members' experiences of working in ICSs is, and how might ICSs need to work differently in order to make the most of the social enterprise sector, if that makes sense?
Yeah, it does, and you know, I acknowledge the kind of elegant architecture that's been established and how we're all meant to slot into it, but our experience and our evidence actually suggests that's not really what's happening. I'm delighted to hear that it is under Patricia's good stewardship in Norfolk and Waveney, but it's not typical. And what we're seeing is that next to no relationship exists between social enterprises and ICSs, and that, you know, is a tragedy given that we deliver 40% of, you know, community services, health services delivered in the home. You know, it's a huge number. It's a huge role we play, and not only in, you know, direct services in the home, but also speech and language therapy, dentistry, community dentists, social enterprise dentists doing incredible work to tackle health issues in young people. You know, there are so many social enterprises at play, and yet they are absent from ICSs, and that's, to be fair, where the power sits. There is some representation on ICPs, but social enterprises are listed there alongside voluntary and faith groups. And I think just in terms of putting it in that category of voluntary, faith and social enterprise, it kind of makes it a bit like CSR. It's like one seat at the board, that's a tick box. And who will we get? Well, we're not going to get that person because they're actually quite challenging. Let's get Dorothy from the British, you know, from another charity, a benign force that might not say too much. And so that's a real challenge. And if you don't have a direct relationship with the ICS, you're very unlikely to get a head contract. And people would say that you would need to have a direct relationship with the ICS if you're going to deliver a head contract. And that puts us in the role of not partners, but subcontractors, and subcontractors of what's left after the trusts have taken what they want, frankly. And we're seeing more and more of this, where they're observing the opportunity for cross-subsidisation or margin on certain contracts, even if that challenges quality or patient service user voice, they will bring it back in. And it's a bit of I don't really believe in, you know, markets in public services delivery, but even if you do believe in markets in public services, these are quite dysfunctional markets where certain providers have huge advantage and huge power, and others that are often right at the forefront of actually bringing voice to communities that perhaps have felt absent from the process, or those that are actually driving innovation, for example. Social enterprises are great at innovating new approaches to public services, and the state is a bit hampered by innovation because it's hampered by risk. And innovation and risk are bedfellows, and social enterprises are doing incredible things to tackle those wider determinants of health, addressing kind of multiple causes, getting upstream, working on much more prevention and community health and well-being and prosperity, not simply trying to address the negative health consequences of our broader kind of dysfunctioning economy. So look, that's I hope that answers the question really, and that's what I was going to say. It sounds like it's great architecture and we've got a seat at the table. The reality is we don't, and the power remains in, I think, old hands, trusts and foundations, unfortunately. And I don't want to necessarily go through a whole range of kind of bureaucratic and administrative reform. But what I would say is we need to be much clearer about the expectation of the way that non-statutory providers are worked with in these new structures and systems that are still evolving. But there's a long way to go, and this has to be tied to economic strategy as well. That's my other point. The consequences of our economy are driven by the
Yeah. No, I mean, it's interesting, and a lot of passion, Peter, coming from you there, which I can feel and hear and understand. And I think, as we've said, it's quite it's a very mixed economy actually out there, isn't it? A lot of different things going on across a very wide system. Thank you for that. Eleanor, building really a little bit from what Peter was saying, I mean, what support or considerations do you think smaller organisations need from ICSs, and also from larger third sector organisations and the statutory sector? What would you say?
Well, I think in terms of ICSs, I mean, we're part of a VCSE alliance in Nottingham and Nottinghamshire, which is great, and it's doing some good work, but I think the pace just feels frustratingly slow. The pace of change and activity, the gap between the meetings, different people come to different meetings. There's a lot of kind of exploration and working out what it is that we want to do, and looking at different models around the country as well, which is all great, and each place has a different approach. But I think for charities and social enterprises who are used to, one of their strengths is their ability to be agile and responsive and kind of adopt new thinking and ideas and take action on them, the whole experience of trying to kind of participate in these sort of structures is just by its very nature incredibly frustrating. And it's just not, I just don't think that it's the best way to go about it. And it would be helpful if somehow engagement in this kind of thing could be somehow incentivized and made much more dynamic. The engagement needs to take place more regularly. It needs to be much more kind of like, we talked about this and then this happened, this action has taken place, there's a forward motion that everybody can see, and then they can buy into it. And the reality is that the VCSEs that are out there, every single one of them, the most pressing need, I would say, I'll take a wild guess, is funding. So that's the prime motivation for kind of wanting to engage. It's to kind of not miss out on opportunities to get some funding to do the work that you're passionate about doing and continuing to do. So finding ways to make partnership working more productive, meaningful, and that you can actually see where it's going, and that you can see that there's going to be a trickle down of some funding here. I think that's what would kind of make VCSE alliances and their engagement in ICS much more relevant. And yeah, I would love to see that happening. I think it's great in theory, and it is a work in progress, of course, and everybody is kind of doing their best. But maybe just it would be great to see some specific ways of funding ICSs to support their VCSE alliances, or whatever shape they take, to really explore some more modern, inclusive ways of procuring and commissioning services. Let's really focus on how we can move to a better model of funding and commissioning, and how can this trickle down to the smallest of our local VCSEs. Surely the universities could kind of get involved with that. I think they are involved, aren't they? They're partners in all this. It'd be great to kind of get them to partner up with the VCSEs and kind of let's really get something moving. and share it. You know, let's try and speed up this process.
Yeah.
Julie,
Thank you.
I know you've got lots of questions. Can I just add a couple of quick thoughts on what both Andrew and Eleanor have said?
Please
Peter
do.
and Eleanor. Thank you, because first of all, there is a problem with the 22 Act, because as a result, ironically, of a Labour amendment, social enterprises aren't allowed, however big they are or however important, and we have a significant one in our system, they are not allowed to nominate or be part of the nomination for a partner member on the Integrated Care Board, on the board of the Integrated Care Boards. They've been deliberately excluded and almost put into the same category, ironically, Peter, as for-profit private sector organisations. So, you know, that is a problem. Secondly, and I think much more importantly, as you know, you will all know, there's a very deep culture within the NHS of suspicion and hostility towards the private sector generally, in part for the kind of reasons Peter was mentioning, but social enterprise is seen as part of that world. And so there are many people in the NHS who do see any change, including integrated care systems, as an opportunity to bring the money back within the NHS. Instead of letting it, you hear the phrase, leak out, and then where is it leaking out into? Oh, well, private providers, social enterprises, we want it back with us, the NHS, because that'll help us solve our financial problems or whatever. Now, I and many others within integrated care systems really resist and challenge that, but it's a deep part of the NHS culture, and so we have to recognise it. But the other problem, Peter, I think you were very eloquently expressing this enormous problem of really good, agile, risk-taking, innovative social enterprises not being able to hold lead contracts or being left with, you know, in a subcontracting position. And Eleanor, you were saying the same sort of thing about, you know, the money's not coming down to the smaller organizations. The flip side of that is that even for a mid-sized system, small to mid-sized system like Norfolk and Waveney, we got forced under a previous government directive, having just been set up, we had to slash our headcount. We haven't got the capacity to manage directly multiple contracts with multiple small organisations, where it's quite difficult unless there is a consortium in place for us to put the lead contract with the social enterprise, even if we wanted to. And Peter, your point about social enterprise being, as it were, lumped in with faith organisations, you know, small community groups, faith organisations, whatever, you're spot on. Now, in Greater Manchester, with the support and some funding from the Integrated Care Board, what is happening is they've created an alternative provider collaborative of social enterprises, very deliberately, not part of VCSE forums, assemblies, or anything else at all. And they're doing it, as I say, with development funding and the explicit backing of the Integrated Care Board, really in order to solve this problem. And I think the 10-year plan, on which I assume, you know, work and engagement is about to start, is a wonderful opportunity for all of us and all of you with your experience who want to see this development, which we need. That's an opportunity for us to do some of the reset we need to the procurement framework and so on and so forth.
Thank you very much. Thanks for that, Patricia. I've got some questions I would like to pose from people that have been putting them in the chat, if I may. So there's one from Philippa Mariani on how can NHS trusts and ICBs use governance and procurement policies to actively promote partnerships. What might need to change to enable this? Peter, do you want to pick that one up?
Yes, I'm happy to. I mean, first of all, thank you, Patricia. I completely agree with you, and I'm familiar with what's happening in Manchester. I do agree there's some great practice happening out there. I think fundamentally, I think NHS procurement and commissioning needs to make use of some of the existing opportunities within procurement and commissioning legislation to reserve some markets for not for private profit providers, mutuals, co-ops, charities. That's allowed for a defined period, particularly where there aren't, kind of dynamic markets at play. Secondly, I think we need to massively increase the kind of social value aspects and weighting in procurement, because the mandatory, I think, statutory expectation is 10%. What do we talk about when we talk about social value? It's back to that idea of a well-being economy. How can our jobs, how can our work, how can the services being commissioned on our behalf actually drive community well-being and individual prosperity and shared prosperity? And we have to take into account, I think, wider impacts. So we have to look at the kind of quality of employment that providers are offering. We want to see wages increase in this country. We want to see work security improve in this country. So let's start, adopting at least 20% thinking around social value. The Centre for Social Justice, a fairly right-wing think tank set up by Ian Duncan Smith, recommended 33% not so long ago. So I think this principle about really understanding Maslow's hierarchy of needs or the wider determinants of health and commissioning actually services on that basis will go a long way to actually addressing the issue of how we kind of prevent illness rather than continue to try and treat it. That would be my quick answer.
Thank you for that. I'm just very aware of time, and so I wonder whether or not I'm going to bring in a question which I wonder if all of you might want to comment on, from Ivan, which is Ivan Albrecht, which is, does a bigger role in the delivery of public services need to mean more or less parity in terms of paying conditions for VCSE employees? Who wants to jump in first on that one?
I'll stick my neck out if you want me to. And I'd make a couple of points. First of all, as commissioners, which is part of what we do as an integrated care board, we absolutely can already do some of the things Peter was talking about. We can absolutely put a higher weight, as trusts can as well, on social value. We can say that part of what we are looking for is a partnership with social enterprises. We might well also say, and with smaller local community groups and so on. You can define what you want. You can absolutely encourage the creation of consortia that are able to bid for a lead contract, or something that is much more equal, put it that way, than the kind of subcontracting arrangements that currently exist. The one thing I would say is the public finances are in a terrible state. Global financial crisis, COVID, I would add personally Brexit, and the war in Ukraine. We in the NHS, but everybody in every part of the public sector is under very strict demands from Treasury to get ourselves back to, the plans we signed up to a few months ago. It's a very tough financial climate, even with our very large budgets. just as it is horrible for social enterprises, the voluntary sector and everybody else. And therefore, I don't think it's our job to specify what each of you should be paying your staff, but if we do specify that we want a certain level of wage for the staff working on our contracts, we have to be able to afford the consequences of that. And at the moment, the public sector in many situations actually cannot afford to pay the uplift in the wages of staff working at the front line, even, on current contracts. So there is, in the short term, there are some really, really hard trade-offs being made. We all hate having to deal with them. More fundamentally, as I say, I don't think it's our job to tell Turning Point what you should be paying your staff generally.
Thank you. Thanks, Patricia. And Peter?
Yeah, thanks, Julie. I mean, I think, again, whether you like them or not, markets exist, and there is a workforce market within the NHS. And I think it's a very slippery slope to assume that, again, philanthropy and volunteers are going to prop up poorly funded wages in our sector. It's not good enough, actually. And I think there needs to be that kind of understanding and recognition that our collective sector, and only charities in that, and community groups and social businesses, are responsive, efficient, innovative, and representative. Much more so than traditional state-established systems and processes. And we should be known for that, not for being cheap partners. And I think too often we're still seen as being, we can get it on the cheap from the charity sector. And actually we are competing for workforce. And actually it's only fair that our workforces are paid equitably with similar roles employed by the state. So, that's how I would kind of respond to that for sure.
Thank you. Gosh, there's so many more questions that we could have asked, and we've been so tight for time. I think we are going to have to wrap up if we're to keep to time. Unless, Eleanor, there's one, I don't know if you want a quick comment on that.
Just to say, I think wages, staff salaries, I think that's one of the key areas where charities end up kind of subsidising public contracts, because they end up spending all of the budget on staff salaries in order to get and keep the staff that they need to deliver that service, and everything else, there's nothing left. So it's a real issue.
It is. Thank you so much. Look, I'm going to have to wrap us up to keep us to time. So I just want to end by saying thank you so much to all of our guest speakers and to all of you for attending today's webinar. I think as we look towards the future landscape of health and social care, these generative conversations really are paramount in understanding not only the challenges that we're up against, but also strengthening a lot of great work that we know is already underway, and bringing together there's a lot of disparity, as we've said, all over the place, but keep building on the best that we've got and keep trying to make the system work, I think is super important. Really appreciate your time to all of the panelists. Thank you everyone that's attended, and I wish you a great rest of the day. Thank you so much, everyone. Thank you.